So TOAST stands for this, a little acronym. Every good research study has to have a good acronym. I didn't design it, some other clever designers did that. And the TOAST study is this. I'll leave you to read it. It's a randomised controlled trial, which is a type of clinical research, for those who don't know, looking to find out if suppressing gastric acid soon after repair of esophageal atresia has a role in preventing strictures. Okay? And one of the important things about this slide is all the other logos on it, in terms of the great extent of collaboration there is across the country. And also a key involving partner in that is the big logo at the bottom. So this organisation that you're all here as part of or supporting today. So we're going to talk about a little bit about what this is all about, why we're doing it, what the background to it is. And then a key part to any clinical research that's a big project is actually trying to understand if the research is doable. Is it feasible to actually do this research? We're going to talk a bit about that. We're going to talk a lot about patient and parental involvement and where we're currently at with it, and where this is going next. So this is a problem that many of you will sadly be all too familiar with. I don't need to talk about it hugely to this audience. But we know that it affects many children following the repair of their esophageal atresia. So PPI on here stands for proton pump inhibitor, a type of anti-acid medication. And we know that from other patient populations that acid reflux can cause strictures in the esophagus, whether you've got esophageal atresia or not. We also know that babies born with esophageal atresia have a high prevalence of reflux. And so there's this theory that's come up that using antacid medication from the time soon after repair might help reduce strictures in babies with esophageal atresia. Okay, that's sort of where this comes from. And as a consequence of that, many surgeons have started using antacid medications routinely following repair to see if it will reduce the incidence of getting a stricture or perhaps the severity of a stricture if it happens. But not all of them. Some are using it, some aren't. And the reason I think that some are using it and some aren't is that we don't know if it works. Okay? There have been a number of research studies done over the past 10, 15 years to try and look at this. And this article that I put up here is a way that researchers and clinicians tell other people what they've been doing, and they publish them in journals. And this is the most recent article that's come up about this particular topic, trying to ask the question whether routinely using antacid medication in children with esophageal atresia reduces the rate of strictures. Okay? And what these researchers did is looked at all the world literature that's been published on this topic so far and pulled it all together to get a larger number of patients to hopefully get more reliable results. They found 10 studies with just over 1,000 patients, actually quite a lot. Most of the children in that had the type of esophageal atresia that's most common, so that won't be a huge surprise. This is one of the figures from this topic, this paper, and I'm not going to get you to read it all in detail, but essentially what it allows them to do is pool all the results of all different topics together and come up with an answer based on all the data that's in them to find out if there's any evidence that routinely suppressing acid is beneficial. And that line, vertical line up and down in the middle, is the line where you can say, okay, to one side of it there would be a benefit, to the other side of it there isn't a benefit. And that little diamond at the bottom is crossing that line, which means there's no good enough evidence to say for certain whether there's a benefit or not. Okay? But what they also found is that all the studies that had been done had all been looking back at patients who had previously been treated. Okay? And the problem with types of medical research like that is there's all sorts of other things that can influence whether children who are given the antacid medication or not might get a stricture. It's not what we call a controlled study. And so they concluded from this that there wasn't any good evidence, but there was lots of problems with the existing evidence that we've got, and we really do need more research to try and understand if this is a treatment that works or not. What do we know? Well, we know, as I said, from studies both in the UK and in North America that around about 3/4 of surgeons are using them. So some of them think it's a good idea, about a quarter aren't using them, presumably because they don't think it's a good idea, but there's variation in practice and no good evidence. We also know from European guidelines and North American guidelines that it's a recommended treatment despite that lack of any good evidence, which is curious, but it's where we're at. So this is sort of a summary of the position where we're at, and we've done work to look at it. We know that many surgeons use these medications routinely. We know that they're generally a safe group of drugs, so you could argue about the risks and benefits of giving them. We know that parents, and I don't need to tell you guys this, that having lots of visits to hospitals for these sort of problems, for having strictures, is a lot of burden and very disruptive. We also know generally that parents don't like giving medicines to their children unless they know there's actually going to be a benefit from them. So what we're trying to do is find out if these medicines really work or not, and if they use harm. Because if they don't work, then we can say to parents, well, there's no benefit from this, you don't need to give your baby these medicines. Conversely, if they do work, we can say with certainty to clinicians that we've shown these work. Every baby should be having them. And that hopefully would result in improvement of care and outcomes for children with esophageal atresia. You might say, why bother? Well, these drugs are cheap, they're widely used, everybody knows they're safe. Why not use them for everyone? And I come back to this concept of, it'd be really nice to have good evidence on which to base our practice. We want to know with some certainty about whether the treatments we're giving to children in particular are beneficial or perhaps they are not harmful. Coming back to the safety thing, yes, these medications are generally pretty safe, but there is some evidence that actually if you block the acid suppression in the stomach, you do expose children to higher risks of certain infections. And there's a wealth of papers actually looking at this in large populations of children. So we shouldn't just be giving medicines to children without actively and consciously thinking about whether they are beneficial and making sure they're not doing harm. So we know it's often used. Having looked at what we currently know, we don't know if they're beneficial or not. There's some evidence say they might be harmful, and there's no really good quality prospective looking forward research on this topic. And so that's what this study is designed to try and answer, this one very specific question. Completely acknowledge it's only one very small aspect of the care of a lifetime of someone born with esophageal atresia, but it's something that we have some control over and might be able to influence what we think is an important outcome. So this is the research question that this project is trying to answer. Now, when you plan a trial like this, there are lots of challenges. Okay? We know it's a rare condition. There aren't that many babies born in the UK every year. We're going to need a lot of babies. We're going to need lots of centres to do this research. We've got to have clinicians who are happy to take part in it. We've got to design it in such a way that parents are going to be happy to enrol their children in it and be happy to stay with the project over a long period of time so we can monitor their follow-up. And it all sounds a bit of a big undertaking, really, and it is, and many people would be put off doing it. But it's important to ask the question if it's actually feasible to do it, okay? And that's why we designed this project in two parts. First of all, trying to find out if it's feasible to do. Secondly, if it is feasible to do, how are we going to do it? I'm going to talk just a little bit about these two stages. And that's even more important because this project has been funded by the organisation that Paolo mentioned earlier, the National Institute for Health Research, the research arm of the NHS, who are using taxpayers' money to fund research. And they don't want to give us a lot of money to do a big project if it's actually not going to be possible to do, because that would be a waste of their money and everyone's time. So first of all, we designed a feasibility study to try and find out if doing a bigger trial would be feasible, with an intention that if it is feasible, to go on and do the trial that we want to do to answer the research question in the future. Many of you in this room might have been involved in the feasibility study, in which case a big thank you. There were three parts to the feasibility study that are shown here. WS stands for work stream, okay? So first of all, to explore the acceptability of what we wanted to do, to look at what the barriers and enablers in allowing parents to say yes to enrolling their children in the trial would be, and look at all the information we were going to provide to parents around the trial and optimise it as much as possible. And also to find out which outcomes were most important from a parental and clinician perspective to measure. We wanted to look at strictures, but we wanted to make sure that that was an important outcome to actually measure from everyone's perspectives. And I said there was going to be a sort of decision point, if you like, after we'd done the feasibility trial to see if actually doing a bigger trial was going to be actually possible. And so we used this, what's called a traffic light system, red, amber, green. And we wanted to find out, as the green criteria were there, we wanted a clear indication that parents were finding the trial acceptable and be willing to randomise. A view that enough surgeons would be happy with the trial and able to randomise their patients, and enough sites in the UK to actually deliver the research, because as you saw on the previous slide, we're going to need over 200 babies. So we set about this doing a series of interviews with parents, surveys with clinicians, interviews with other clinicians, and then some focus groups as well, to really try and delve down into a number of different aspects about the trial. So we asked a whole lot of parents to get involved. As I say, many of you were involved, and if you were, thank you. And we tried to get a representative group of children who'd relatively recently had this experience of having a newborn baby with esophageal atresia, and asked them for their views about various aspects of the trial. And I'm not going to go into detail for time. We have written this up in a paper if anyone wants to read it. But the general view was that everyone thought this was a good idea and was happy and thought it was an acceptable thing to say yes. And the vast majority of parents straight away said yes, they would have allowed their baby to be put in this trial, and the other three had a little sort of few tweaks they recommended to what we were planning on doing before they would be willing to say yes. The value of this sort of qualitative research and interviewing people is you get really detailed information from parents about some of the things. And so these are some of the quotes there that I'll just leave you to read back from sort of things that we can get. And we can look at these and really try and find out in detail what parents think, and that can really help us inform some of the work we do. I said we wanted to find out what outcomes we were going to measure, and so we asked parents what outcomes would be most important to measure. There's a whole load of things you could measure in this sort of situation, obviously. And we asked parents and clinicians to rank these outcomes in order of what was most important. And you can see what they found here. The severity and the incidence of stricture were really high up on their list in terms of what was important to them in those early years of life. And we used these to put together that list of what we're going to measure in the trial. Parents also told us about some additional outcomes they thought were really important that we should look at that we hadn't originally put in the list. And that's allowed us to take those and consider in putting them into our trial process so that we can measure these things as well. Really important because we know that parents, because they've told us, found this important. We also asked clinicians, and as I said, we did a survey and interviews with them. The vast majority thought it was an important trial to do, but not all. And at the end of that feasibility study, we found that we've got practitioners across 20 different hospitals who said they would find the trial acceptable and they'd be willing to recruit into it. We found that there were a few little things we'd need to tweak. We found there's high parental support for going into for doing the research. And we, as I say, got lots of further perspective with parents and clinicians through these interviews and focus groups that we could build into it. So overall, at the end of that feasibility stage, we thought we can do this. Okay. So then moving on to the actual trial part. As I said, this is the question that the TOFS trial, the prospective research we want to answer. And the way this trial is set up to be is a randomised trial in babies born with esophageal atresia. So the concept would be that soon after repair of their esophageal atresia, clinicians across the country would be approaching parents and asking them for permission to involve them in this trial, where we would randomly, so by chance, split the children into two groups. And neither the doctors nor the parents would get a choice about which group they go into. And that's how we remove other things that might cause some bias between the two groups. And one of the groups would get routinely given antacid medication, and the other group would get a matched placebo. And you wouldn't know what you were getting. And that's really important, because when we look at the outcomes, it's really important to make sure that nobody knows which group those children are in at the end, because that might also influence how we understand what the outcomes are. So this is what we're planning to do. And the primary outcome that we've settled on, based on feedback largely from parents and also clinicians, is this: the severity of anastomotic stricture, which is defined as how many dilatations a child has within a year of trial entry. Okay? And these are the key secondary outcomes that we know are important to patients and families, in particular, that we will plan to measure as well and be able to say what the incidence of each of these things happening is and describe them in the two different groups. So we'll know that whether the antacid medication impacts the severity of the stricture, but also the impact it has on any of these other outcomes that are here as well. And we are as certain as we can be that we're measuring the right things because of the process we've been through to get there. This is a huge project. Okay, we need to recruit 200 babies, and we're aware that not every parent of every child born with esophageal atresia is going to say yes. And so it's designed to go over an 8-year period. Sadly, we've had lots of delays. And the primary delay we have is around getting the medication that we need to deliver in this trial in the right format to keep the trial regulators happy to be able to use in a trial. And so despite you all knowing that you can get antacid medication such as omeprazole or other azoles out there relatively easily, it's not currently available in the right format to use in a clinical trial in research, which is hugely frustrating to say the least. And we are currently in the process of working with a number of drug manufacturers to try and essentially develop a product that can be used to meet the regulators' very high demands for this. It's absolutely crazy and driving us mad, but it's where we're at. So we've got a trial that's designed and ready to go, and we're just now having to essentially go through a process which is a bit like designing a new medicine from the word go to actually get one that's deliverable in a trial. So watch this space because this will be coming, but it's not here just yet. As it says there, we can't wait to get started. Just before I finish, I just want to mention two things. So I think having a big prospective randomised trial like this really feels like it's representing a significant milestone in the generation of evidence into supporting the best care in this group of babies and children. There's not before been any large randomised trial that rigorously evaluates the impact of any treatment at all, actually, in children born with esophageal atresia. And to have got a lot of money from the National Institute for Health Research, this is how much, to do this big project, is actually a real achievement. Okay? And it's only been possible through really close engagement with patients, families and TOFS in order to do that, because we didn't have that link. There's no way we would have been able to convince the NIHR to give us this money. The other thing I just want to mention is that behind this project we have got a fantastic group of some patients and parents who have helped us at every step of the way. Graham talked about co-developing research, co-designing research, and really this project has been all about trying to incorporate the views of people with experience of this condition into it from the outset, because we recognise that unless we do that, it's not going to be successful. And so we've got a fabulous group who meet regularly, certainly through the feasibility stage, and we'll continue meeting with them to understand how to deliver this project in the way that's most acceptable to the people who are going to be participants in it, i.e. children and families born with this condition. I'm going to finish there. Thank you very much.